Good morning, everyone, and thank you for joining the Center for Disability Empowerment's Emergency Readiness series. On Monday, for those that were present, we talked about the active shooter part one preparation presentation, where we learned a lot about affirmative speech, mind setting, and also learned about how our nervous system can affect our reaction to an emergency, as well as techniques to help us calm our central nervous system. Today, we are going to be talking about part two, trauma care for civilians. And before we get started, Erin, do you mind telling us a little bit about this topic, why it became part of your curriculum?
Absolutely. That's a fantastic, Marley. Thank you, or fantastic question, Marley. Thank you for asking. Um, Originally, when topics like this, so what originated as workplace violence and then school shooting training years ago, you're talking 2005 through 2010 for the most part. The main focus was on large group response around lockdowns and around the potential of swarming a bad guy. As things started to evolve and people started to realize it's a little more of an individual approach, which we discussed in a lot of detail on Monday. We'll talk about a little more today as well. They started realizing that okay, there may be a little bit more to this. If we're expecting civilians to not only protect themselves, however, possibly fight, there may be some other elements to this as well. And it was actually early in 2015. We taught a lot of seminars in 2015, more than 80. And uh, a very good friend of mine who we'll discuss today, his name is John Grabo. He was one of my self defense instructors, and he's also a firefighter, EMS. And he actually approached me and said, "Hey, have you ever thought about adding civilian medical care to the curriculum?" And so, honestly, it was John's idea. And it was fascinating because in the firearms industry, um, in the tactical industry, you'll find organizations that were teaching essentially what would be considered some type of emergency medical care in the field. And however, it stayed for the most part in those industries. So if you were in the firearms or tactical self defense realm, you knew who these companies were. They weren't at the time really exposing themselves to everyday civilians. And so John actually, when he came up to me with that idea, that was fascinating because no other organization teaching active shooter response in any way, shape, or form at the time was doing that. And there weren't, again, like I said, many organizations offering this to civilians in general, at least not in a wide range. So we started playing with it. He had already developed a curriculum for what he referred to as immediate casualty care, which is what we're going to talk about today, and had already been speaking with certain communities and organizations about it in the context of everyday stuff. If you get into a car accident and have, an extreme break in like an open dislocation, how can we stop severe hemorrhaging and blood flow? So he already had this idea and this curriculum of how it went, and we started putting it into the context of this training, and little by little evolved it to become a staple in the program. And one of the reasons that it's continued to become more and more important to me personally in the way that we present the active shooter response program is because if you think about any given event like this, let's say there's 50 people in a classroom and a shooter walks in and he shoots and maybe 5 to 10 people are shot, so now we have 40 other people involved. And then even if the shooter is rushed, let's say 5 people get involved with rushing him, so I now have 35 other people that have something they can do that doesn't involve fighting, doesn't involve barricading, especially if the fight's already been resolved in some form or fashion. So there's just all these other areas and things that we're simply being overlooked, where we can stop the dying. And that's a big a term we often talk about. You know, the first priority is to stop the killing, so that's to stop the threat from injuring more people, and then immediately or as soon as possible, we want to stop the dying, and that means anyone who is still alive and has suffered some type of an injury, we need to get them care as soon as possible. Well, the earliest people, the people that can give that care fast, are the people that are on site. And what we'll discuss in here, in length over the next 2 hours, is it's not what most people imagine, which is like surgeons and all this crazy equipment. It's how do I buy time so that EMS can come, and then they're going to give a higher level of intervention, which will buy more time, and then get them to a surgeon, which will buy more time, and then that's the timeline that it goes on. So full credit goes to John Grabo and the Immediate Casualty Care Program for bringing this to light. And then honestly, the evolution of it, as we discussed in the last one, is really a testament to the tens of thousands of people that we've worked with over the last couple years and their feedback. This made sense. This is easy. This was difficult for me. What would we do in these situations that allowed us to actively evolve this system? And again, to John's testament, he has continued to evolve the program and really get it out to civilians in general. So that's the timeline of how it's coming. To be completely honest, in the grand scheme of things, I come from a fighting background. I've taught self defense for a very long time. I have put the medical care portion of it above the defense and fight back as far as overall priority and practicality for normal everyday civilians. Even though that's my background, is in that realm, and you start to really realize just how important it is. And what you'll find out very quickly is very simple with the right amount of training behind it. It's very doable.
Mhm. I remember we talked about this. I was like, "Oh, this might be a little bit outside of our range."
Hmm.
And when you explained it to me, it was like a light bulb that clicked, and I was like, "This makes perfect sense."
Yeah.
Even as you said, in everyday activities, someone falls and hurts themselves very badly or impales themselves on something. My dad is a double amputee and a diabetic. So if he's ever in a car accident and I'm there helping stop the bleeding as much as possible can keep him alive longer, right?
Hmm.
And that's what the goal is for this type of training.
Yeah, and there's a lot of with many things. There's misconceptions, misinformation, and oftentimes that's due to a lack of exposure.
Hmm.
Um, and we discussed that in depth on Monday. That idea of familiarization. The more I understand things, the more I can see where I fit into those elements. And when it comes to medical care is one of those things that in the modern day world, we have the more we've created professionals, so doctors, surgeons, EMS, firefighters, the less we have become engaged in those areas. So we talked about this a little bit on Monday, but the idea that 100 years ago, the fact that I could possibly get an ambulance in my driveway within 5 minutes is unheard of. So we had to understand basic life-saving protocols to a certain extent so that we could, shove them into a buggy or a car and eventually get them to a doctor somehow. And the more we've created professionals, we've distanced ourselves from those areas. And it's good that we have professionals. However, we should still have a finger on the pulse of how to care for ourselves generally, especially because if you look at an active shooter situation, and again, we'll dive into this a little deeper later on, EMS, you may be able to get an ambulance on site in 3 to 5 minutes. However, the law enforcement department has to declare the zone cold or safe before they're going to start sending untrained medics into a violent scenario. And so now, if you look at situations, and we can go to some crazy outliers, but if you look at the situation like Pulse nightclub in Orlando, that many people are very familiar with, that turned into a 3-hour situation. And yes, they were sending tactical medical teams in to work on, a couple groups at a time and remove some people out. However, the idea of getting a bunch of support inside of that building took hours. And there are actual scenarios that we can touch upon where 2 or 3 people through witness testimony have, let's say, hinted to elements that people that understand where they're at is a friend of theirs or someone in their proximity had a wound that could have been cared for, but because it wasn't cared for over 2 to 3 hours, that was the reason they bled out and died. And so, had we been getting this type of education to the public a lot sooner, now all of a sudden those people that were in that what turned into a hostage situation could have been doing direct pressure, could have been doing packing wrap, with toilet paper, paper towels, things that again we'll discuss in more detail moving further, had we been giving that information out. And to the federal government's credit, much like we really pushed CPR a long time ago and really made that part of like, hey, everybody can do this, we can get hands on. And, like the hands only policy of like, look, even if you're not CPR certified, giving compressions can help at least circulate blood flow and keep them alive long enough. Um, they started the Stop the Bleed campaign. I want to say 4 years ago, maybe like 2016. I could be wrong on that. And that is essentially this. It talks very severely about just very simple measures in mass bleeding, mass hemorrhaging situations where everyday civilians can understand and learn how to apply direct pressure, how to pack a wound and then wrap it securely, and then discuss tourniquets. And so as this information is getting out there, we start seeing, just like you are, oh wow, there are things that I can do that are inside of my capability. I can focus in those areas to get that intervention there as soon as possible. As Marley mentioned, my name is Aaron Janetti. For those of you that were in attendance on Monday, we laid out the overall look at what preparing for an event like this looks like. We discussed the psychology, we discussed um, the way we should be viewing, adapting, and creating our own individual response. And then we started diving into getting away and keeping away in those elements and aspects. Today, we're going to spend a big part of this talking about trauma care specifically. And then we are also going to look at application in everyday life, and then discuss interacting with responding units, which is another area where there's a lot of misinformation that can cause frustration in an event. And the more we know about how those processes work, the more we can be helpful in making those things go a little bit smoother and a little quicker, and then also be empathetic of what everyone's roles are and understanding what everyone's roles are there. So if we look from the top, we're going to view and discuss briefly again, looking through the eyes of what is possible, which is super important. We're going to talk about the difference between trauma care and what we all know as first aid or CPR. We're going to look at practical application of care for civilians, which is what I usually refer to as the immediate casualty care protocol. We're going to talk about awareness, safety, stopping the bleed, and techniques that are involved in that. What to do with head, chest, and abdominal wounds and the considerations in there. Airway and shock, which are some other things that can come up. We're going to talk about improvised versus prepared care, and then also how to prepare for those types of events. We're going to discuss building a medical kit or a trauma kit in different variations. I have some examples right here on the desk that I'll actually show you that are ones that I use every day or have available every day. Thankfully, fingers crossed, I have yet to have to use them. We're going to talk about application for everyday life, where we can apply these other concepts into different areas, incidents, accidents, all that. And then we're going to, like I said, discuss a lot about interacting with responding units. The big thing, and I made this mention on Monday, is that this is for you. I have an outline. I have some slides, obviously, that we're going to work our way through. However, any question that comes up, please pose those questions. I am going to allot a 15 to 25-minute section at the end for us to answer any questions like we did on Monday. So definitely ask them. And I really want to make sure you're comfortable with the material as we move past this. So one of the things that comes up, and we talked about a little bit with the exchange with Marley and I early on, is the idea of helping versus saving. And when we think about giving trauma care, we oftentimes will imagine, doctors and medical professionals and techniques that we may assume is out of our pay grade. Um, where I really want you to view is that this is a process. Getting somebody from traumatic injury to recovery, whatever that recovery looks like, is a process. It's a long process and it's a team effort. And so even from the interaction of what we do as civilians on site with them, to then what EMS does to treat them and get them to a hospital, to what the surgeons do, to then the recovery after. So then you're talking about doctors and follow ups and nurses, and then everything that goes on with the family. If you look at it through that perspective, each person has a role. And if we look at the timeline of an injury, the sooner that we can give medical intervention in any way, shape, or form, the better the chances that person survives. And so if we think about it through this idea of, okay, I'm helping, I'm buying time, I'm part of this larger team effort to save this person's life through it, I'm going to play my role in it. We can start to understand and accept that level of responsibility more than if I do this and it doesn't work, like, oh my gosh, I didn't save their life or I did something improperly. Where what we really want to look at, and one of the references I usually make is this is duct tape medical care, right? So if I have a leaky pipe in my house, I may tape over it briefly until a plumber can get here to actually give it its needs. Well, that's where our role falls into this. There's a lot that we can do immediately right now that is inside of our ability level, inside of our resources, that will buy time to keep it from becoming as catastrophic for then the next level of intervention to get here. And then they will do upgraded medical care. Maybe it's IVs. Maybe they fix a pack and wrap that we did and make it a little more secure. Maybe they apply a tourniquet or a secondary tourniquet. And then that's buying time to get them to the doctor or to the emergency room, where then they're going to have surgeons that are actually patching them back together, stopping blood loss, those things. And so it's this entire process. And so understanding how to treat severe injury is part of this personal protection journey. It's part of this responsibility that we get to have in our lives to make sure that we stay safe. So when we talk about self-defense, we, as in, my facility and our training instructors, we're looking at everything that encompasses protecting myself, protecting my family. And a big chunk of that is knowing what we're capable of doing to allow ourselves to deal with injury until we can get to, again, a higher level of intervention. So this concept and idea of this being out of our pay grade, when we start looking at it through the view of I'm part of the entire picture and I'm buying time for this individual, it becomes more practical and a little bit more palatable for us to take on that responsibility to do that. And that's exactly what our job is. We are one link in the journey for them to get to safety. And yet we're a super important link because, as I mentioned again, and you'll hear me say this quite often throughout this, the sooner that we can give intervention, the higher the likelihood that an individual survives an event like this. So we're the first one there. We want to give that intervention if we choose to. So, very much like we talked about on Monday, we always want to look through the eyes of what is possible. It's very easy to find all the things that we can't do or shouldn't do. If we do that, we start to limit our vision and eyes on what can be done. Whereas if we take all of those can'ts and don'ts, we talked about negations and affirmations on Monday a little more in depth, and we focus on what we can do, then we can keep our attention there. We can do the things that we can do that we're empowered to do. And that's going to help along this entire process. So the negation to affirmation, as a little bit of a review for those of you that were here Monday, and maybe as a new topic and idea for those of you that are new to this, negation is any thought that goes through my head that involves a not. So can't, don't, won't, shouldn't. So if you hear sentences like that, well, I can't apply a tourniquet, or I can't help somebody that has a wound in their chest. If I focus on that, it brings my attention to the thing I'm trying to avoid. And in this case, I want to help this person. The thing I'm trying to avoid is the inability to help. Whereas if I flip it around and go, I can help buy this person time in their medical journey, then we can start to take care of it. I can pack and wrap. I can give direct pressure. I can apply a tourniquet if one is available to me. And I start to flip this on its head. Again, the more time that we familiarize ourselves with these concepts and ideas, the more comfortable we come with them. So the fear, again, that we discussed on Monday of the unknown, the more we practice with tourniquets, the more we understand how tourniquets work, and the more confidence we have applying a tourniquet, the more we understand how to talk to 911 when we call them, the more confident we're going to be in our ability to do that, and the higher our likelihood to be able to do it under stress. And so the more time that we spend familiarizing ourselves with the topic and actually spending time training and practicing, the more effective we are going to be in a very dynamic, violent event like a mass shooting or any type of mass violence. Again, I mentioned the idea of duct tape medical care, and that's where we're at. So I want to focus what I can do to help this person until I'm able to get them a higher level of intervention. And that's where everything that we're going to focus on moving forward, we're going to focus on in that idea, which is this is possible. Okay, well, what if I don't have this? Okay, then we just don't have it. We accept we don't have it. What do we have access to? Let's focus in that area. And so we want to make a meaningful distinction between first aid and trauma care. Now, first aid certifications, CPR certifications, things like that are very common. In a lot of professions, they're required. So to get a certification in the original system I was under in Krav Maga, before you even went to get your certification, you had to have proof that you were first aid, CPR, and AED certified. And so, in a lot of areas, especially anything with medical care, anything with schools, anything with large organizations in some form or fashion, there's usually a person or persons on the staff that are required to have some type of certification in those areas. Those areas are different, though they can be similar. Those areas are different than what we're going to discuss. And so, usually, when we talk about first aid, CPR, AED certifications, we're looking at how to deal with choking, heart attacks, drowning, broken or fractured limbs, usually to a smaller extent as opposed to a massive femur break, open dislocation style, which is going to have a lot of bleeding, compounded with it. Allergic reactions can come up. Again, we were mentioning cardiac arrests and other things there. Heat stroke is another one that'll come into those. And these are more likely to happen in day-to-day life. These are things that can happen at a higher frequency than that of a mass shooting event or a traumatic car accident or finding ourselves the attack of violence. So usually these are more practical for people to learn right out of the gate. However, as we've developed and we've gone through the years and started to realize that, again, it's our responsibility to take care of ourselves. Violence does happen. Very traumatic accidents can happen. We're starting to really push people's attention towards, okay, we want first aid, we want CPR and AED training, and we also want trauma care training and stop the bleed overall, which is really good. As I mentioned, some elements and procedures are very similar. You'll see some of the protocols as we lay them out for the immediate casualty care protocol that there are various similarities in how we address it. But we want to understand the difference between those two. So, that said, even though we're going to talk more extensively about trauma care, blood loss, and dealing with those types of injuries, do keep in mind that first aid and CPR can be beneficial in these events. If I have somebody that has a heart attack due to the stress of the event, then my first aid and CPR training is going to be very helpful in that perspective. And so they may not have been a direct victim of the attack. However, that's a really big component to understand that there are still issues of trampling injuries in large events where people are moving quickly in one direction. We still have issues of heart attacks. We still have issues of strokes and things that can happen as well. And so that's where first aid CPR training will be beneficial in these events. The one thing we discussed on Monday that was super important is remembering to look and adjust techniques and tools to our context. How does this fit my needs? How does this fit my ability and resources? And then how do I prepare for the context of my life? So if that's our first aid look, trauma care is generally going to be looked at massive blood loss. Massive blood loss is going to be one of the more major issues that we're going to run into when we talk about people shooting, people stabbing, the possibility of explosions. And so when we get into the idea of massive bleeding, things start to shuffle around a little bit from these standard first aid protocols, where one of the first things, generally speaking, I would do in a first aid situation is call 911. In a massive blood loss situation, every second counts in stopping that blood loss. And so if I take the time to get my cell phone out first, dial 911 and talk to the 911 person, assuming maybe I'm the only individual there to do that, this person may bleed out, where we may shuffle things around and address the blood loss the best that we can now, then make the 911 call and balance that in and out. And so you'll see a shuffling of priority when we talk about certain interventions and how they should be addressed moving forward. Um, as I mentioned, most injuries occur during events like this are massive blood loss. And so that's where we're going to be focusing a big example of what's going on. The blood loss generally, I say most often, there are situations where there may be a difference in this. However, in these events, blood loss should be stopped most often before any other intervention. And so one example of that would be if I have somebody that is, I assume is having cardiac arrest, is having a heart attack in some form or fashion, in any way, if I start to give CPR before stopping the mass bleeding, I'm going to be oxygenating blood that then spills directly out of the body, and I'll be giving compressions that are actually recruiting and promoting blood coming out of the body. And so it's a really tough area to find ourselves. And again, we're going to talk about making tough decisions. It's a tough area to find ourselves where, well, they're not really breathing and they also have this traumatic hemorrhage that I need to deal with. And if we look at it in order, we technically want to go with blood before we go with airway and any cardiac issues, cardiovascular issues there. And so again, it's we start learning these areas where blood loss starts to be the main focus in trauma care versus that of first aid. Okay. And so again, we're creating this distinction between the two when we use the terminology moving forward. Um, the other things that we want to be looking at, depressurization of the lungs, or pressurization of the lungs, and we'll talk about that. And then shock is going to be another big one moving forward. And all of this, we will show you how it's addressed. Right now, we're making the distinction between what you're going to learn in a first aid CPR AED class and what you'll be focusing on in trauma care lessons. So as we continue to move forward, we're going to talk about practical applications for civilians. Okay. And so we want to make a distinction again between not only first aid and trauma care, however, also between professional trauma care with the resources they're going to have and civilian trauma care with the resources that we're going to have available too. And that distinction is important again as we dive deeper into this topic, because even if I am a surgeon, I'm a medical professional with, let's say, a decade of actual surgery experience with me, if I find myself in the midst of an active shooter event, I'm used to performing my job in a sterile environment with a support team and direct access to all resources that I would need. That would be high level trauma care, that is surgery. When I'm finding myself out in, let's say, a mall, I don't have the support system, I don't have a sterile environment, and I don't have all of the resources, generally speaking, that I would normally have in an OR. And so I want to look at a different approach to trauma care when out in what we would refer to as the field. And that is, if I have a medical kit, okay, I can use those resources. If I am unable to get access to a medical kit, I have to look at improvising resources. And so there's a difference between what an EMS person is going to have access to and be able to do as far as intervention, what a surgeon is going to be able to do and have access to, and what any individual with previous training or not will be facing when they find themselves in the midst of an event. And that's really important to look at there. So I mentioned again immediate casualty care. This is a protocol that we are going to discuss. It's also the name of a company. The gentleman by the name of John Grabo that put this together, and he has a wealth of information on this subject and topic. We're going to look at a couple of his videos, or one video specifically in this presentation, to give you an idea of some of the application of a tourniquet later on. However, I want you to be aware of what John is doing with the immediate casualty care program, because he has resources for the public, both from supplies and tools that we're going to discuss later, and also in training that you can really get into this idea of what I can do in the field in these big events. And so there's many programs available out there that are now practicing civilian trauma care. Some of them that I'll reference you to later, like Dark Angel Medical, North American Rescue. Immediate Casualty Care is one locally here in Ohio. He's based right here in Columbus that you can get a hold of. And again, his specifically addresses trauma care needs for life and violent counters, which is very good for what we're looking for. His concepts and techniques are very simple. They're applicable to varying individuals, varying backgrounds, and varying levels. And so again, a lot of what I'm going to discuss and what we believe in here with the ASR program was rooted in John Grabo's findings and the evolution of our system as we've gone forward with this. So it's one thing I want you to keep in mind. And I also want to make sure that I'm doing my due diligence in giving appropriate representation where it is. A lot of this information is coming from John and all of his work and research put into this. So one thing I want to make sure everybody's aware of. So if we look at the immediate casualty care protocol, or the overall plan, we want to look at, first and foremost, awareness and recognition of injury. After that, we need to make sure that we're safe. Once we understand that we know there's an injury, what the injury is, and we found ourselves into safety, the first thing we want to start looking at is keeping the blood in the body. We're going to look at 3 versions or techniques or concepts, I would really say, that can apply, and that's going to be direct pressure, pack and wrap, and tourniquets. Once we've addressed massive hemorrhaging, especially from external areas like the limbs, then we can start looking at chest wounds and what that would look like in compression of the lungs, more commonly referred to in the medical field as pneumothorax, big fancy word for compression and crushing of the lungs. Head and abdominal wounds, we're going to talk about considerations for that, which are going to start taking us a little closer towards that area of, yes, I'm limited in resources and out of my pay grade. So what are the things that I can do? Then we'll talk about airway. We'll talk about shock. We'll talk about the idea of checking for any additional injuries or other people that need injury. And then I go right back to the top again and do the whole assessment again. Where are the injuries? Am I still safe? How are the blood loss interventions, chest wounds, headways? And I work my way through this protocol for the most part, top to bottom, not necessarily in order. However, it's a very good template to start to follow. So if we dive a little deeper into this protocol and this plan, we start with identifying injury. And now this is where we're going to really get into areas in which, if I'm a wheelchair user, if I have any type of paralysis in my body, this is going to be really important. Also, if I have any visual impairment, this is going to be important to understand how we identify injury, because I may not feel a bullet. I may not feel an injury. I may not know. I may have felt it if I'm visually impaired. However, I still need to identify and locate it. And so being able to adjust these techniques and these concepts to my context, and then also anybody that is in my life that I want to help them or have them help me, having them understand how to identify these things as well is super important. So some injuries can be very, very obvious. If you look at the Boston Marathon attack with the explosions at the finish line, you have a lot of blast injuries, and a lot of blast injuries, you're going to have very obvious injuries. The farther that you get away from those, you may have slightly less obvious injuries. You might have, popped eardrums. You might have some shock from both the impact, not necessarily of anything physically hitting me, however, the waves of the explosion hitting me, and then also the trauma and stress of that. As we get closer to that explosion, it's going to be very obvious what those were. There was a lot of limb loss in those situations. And so those are very obvious. massive blood loss can generally be very obvious. Some require discovery. And so learning how to get into, okay, where do I find these? What makes it easier for me to find these? And what's this procedure becomes important. And we want body checks to be part of our plan. And so if we go back to Monday's discussion, I'm in an area and gunshots start to go off and I take off running and I get to wherever I need to, or somebody helps and assists me and I'm able to get my wheelchair to a safe location, or I take my walker and I move to a safe location. When I get there, even though I may not have felt an injury, I want to be in a habit of doing a body check. Under adrenal stress, our body can actually shut down and numb some of our senses. And so, what can happen is we can actually get stabbed or shot or have something slice us open or actually lose a piece, a finger, anything, and actually not realize it because our brains were so focused on get away from the threat. It's overloaded with so much data that it starts to prioritize things. Okay, well, yes, you got shot. However, your brain is going, we need to get away so we don't get shot anymore. And it prioritizes that. And so, actually taking time when I find myself to safety to do a physical body check, taking my hands, running them up and down my arms, running them up and down my legs, having someone else do that with me, up and down my back and my chest to discover any less obvious injuries is a good habit to get into for any self defense protocol. So, as we mentioned with adrenaline, stab wounds and gunshots can actually feel like punches. In the self defense realm and in that industry, we've talked to many people that have been in situations where they got stabbed 2 or 3 times and were unaware they were being stabbed because it simply felt like they were being punched multiple times. They didn't realize they were stabbed until they physically felt and saw the blood. And so, we want to really be cognizant of the importance of body checks, taking time once I've arrived to safety to see, okay, what am I dealing with? Is there anything that I'm missing? Again, as we mentioned, if you lack sensitivity or sensation in a certain area, even more so, we want to make that a protocol. Marley brought up a fantastic question or topic, or actually, no, it was Julie on Monday brought up a fantastic topic, which was, hey, if I'm on a second or third story window, I heard you can survive a fall like that. And one of the things that Marley had mentioned was, well, I may not even feel my legs. So if I fall and I break something, I'm not necessarily concerned about that. And from a pain standpoint, agreed. However, that lack of sensation in the leg, if that causes blood loss, that's something that we really want to look at and understand. Like, okay, I may not feel this. However, I still need to keep the blood inside of the body. And Marley, I see you unmuted yourself. Please add in.
Yeah, so well, after I made that comment that on Monday, I started thinking about it and I was like, well, if I dislocated my leg, it would still really suck. I mean, it would still like there should potentially there could be long-term effects from this injury for me.
Mhm.
A spinal cord injury, you have lower circulation. The time to heal and recovery could take even longer too. So yeah, in that moment, I might jump out of the building, but it's the aftermath might be a little bit longer than I would want it to recover.
Yeah, and that's a beautiful point you brought up, and thank you for that. The What we're going to discuss in part 3 of this, so on Monday, is going to involve the long-term effects. And we discussed this a little bit on Monday, and we'll definitely discuss it more today because this is an overarching topic in surviving a violent event in general. And that is the idea that I'm going to have a perfect plan and execute a plan perfectly, and it's either going to be right or wrong. I'm either survive perfectly unharmed or don't, is rare. Generally, what we're doing is, what is the best case scenario? So if I am on the second story floor and they're going to come through, like if you look at Virginia Tech, the Virginia Tech shooting is a prime example of this. There was one teacher that actually blocked the door with his body and held it shut, while his students jumped out the second story window. And in that case, if he thought that people were going to get through the door or the shooter was going to get through the door, then jumping out the window, possibly having long term medical issues, may, in your mind, be a better benefit than risking being shot multiple times and facing possibly certain death. And so it's a matter of making the best choice possible in these areas. Where the body check would come into play in this case specifically would be, Marley, had you decided to make that jump out of the window and you hit the floor, you may, because of your current situation and sensitivity or sensation in the legs, and on top of that, doubled with the adrenaline going through your body, you may not feel an injury. However, by taking the body check and I can identify it, and once I identify it, I can then render whatever care may be normal. So that's a great topic to discuss, and one other reason that body checks can be so important in a basic protocol. And so if we look at normal procedure, it's running my hands up and down the body, physically touching it. If I have visual impairment, that's going to help as well, because now I'm feeling for fluid and liquid. And then once I find an area where maybe there's a mass pooling of liquid, I'm feeling for the hole. And I'm going to use that sensation of touch to identify how severe is this bleeding, and then maybe what intervention do I need to add moving forward. If at all possible, remove clothing, search under bulky clothing to make sure you're getting good feedback. We're heading into winter here in Ohio. If I'm wearing a big, puffy coat, I may again not realize the injuries that may be going on underneath. I may not see blood because there's a small hole going through my shirt and I may be bleeding underneath. Or it may look like I'm bleeding in my leg because I got shot up top. The blood is trickling down underneath my jacket and then soaking into my pants. And so again, that extra little bit of feedback can be very important. And again, both for yourself and for others that you're with. So as we mentioned, adrenaline can allow us to move and operate with injury. I have a very good friend of mine who's a Brazilian jiu-jitsu instructor that was shot 3 times in the leg in Rio de Janeiro, a little bit more than 2 decades ago. And he ran 7 blocks before he realized he was shot. And so adrenaline can do amazing things for us, and we can definitely leverage that in a self-defense event. We want to make sure that we're also cognizant, aware of signs and symptoms of injury. So some things that may come up, pain is an obvious one, tension, numbness, shortness of breath, tension in the chest, chills, paleness, clammy, things that may identify to oncoming shock, massive blood loss. So the body is losing that blood. It starts to cool, and other things. And generally speaking, symptoms that are out of the ordinary, right? Again, if we look at the context of our life, if there's a numbness or pain that is commonplace in my life, then I'm looking for things that are uncommon. And that's a big deal to again, decipher between the symptoms. So once we've identified what an injury is, we want to make sure we stay safe. We want to check our surroundings. If let's say that I'm out with my wife or my kids and my wife gets shot or injured, if I am behind cover and my wife is out in front and still in danger, emotionally, I'm going to want to go help her. Strategically, if I run out and then I get shot, I am no longer helping myself or her, and then we both die in that area. And so that idea of strategic versus emotional response and respecting both sides of that is really important to make sure we understand how to actually give care. And so we want to find preferably a safe place before we actually address wounds. And so the getaway and keep away discussions that we had on Monday are very important to this and may involve me moving someone with me or having someone help move me to get to an area where we can then give further intervention. Call 911 when possible. And it's important, again, to delineate when possible. If I'm still in danger, then I want to get out of danger before I call 911. If I have massive blood loss, I may need to address massive blood loss before calling 911. And so I call them when it is possible to call them. Another really big topic is buying time to buy time. So, for instance, maybe I'm in an office building and I know that there's a trauma kit or a stop the bleed kit down the hallway. However, I'm bleeding right now. And depending on my injuries or my current context and situation, if it's going to take me a minute, 2 minutes, 3 minutes to get down that hallway and get to that container, I could bleed out or severely lose blood that makes that intervention less effective by the time I get there if I take that 1 minute, 2 minutes, 3 minutes. And so I can do on intervention now immediately. Let's say I have a gunshot in my leg. I can take my shirt, tear it off, pack the wound, which we'll discuss, so that I can buy more time and slow the blood loss to then make my way to the medical kit where then I can access possibly a tourniquet or a higher level of packing, something that's going to be a little bit better. So I'm buying time with a quick intervention to help so I can get somewhere more secure to address a higher level of intervention. We mentioned this already, the idea of we don't want to get shot trying to help someone else. And again, that can be very difficult to comprehend emotionally on both sides. If I am injured and I'm lying down and I want people to come help me, I also have to understand that if they come out and help me and I'm in the danger zone, that I'm putting them in danger in that perspective. And so a little bit of strategy needs to go into that as well. And then again, these conversations apply to loved ones and support personnel, and we want to make sure we're having them and opening that line of communication. So now we're getting to the main intervention, the first piece of the puzzle. External blood loss. Okay. External blood loss is going to be where we can focus a high majority of our efforts and make the largest impact. And so external blood loss, generally speaking, is going to come from large muscle junction points like the shoulders and hips, even up into the traps, out to the limbs, so the arms and the legs. When we start getting into the cavities, right? So I have my chest cavity, which is a sealed compartment for my lungs. I have my abdominal cavity, which is a sealed compartment for the remainder of my other organs. And then I have the head, which we're going to consider a cavity because it encapsulates the brain and you have the blood-brain barrier and everything that's important there. When we start getting into those areas, things start getting a little less, let's just say it's more important for them to get a higher level of intervention. This right here, external blood loss to muscly junction areas and limbs, is really where we can make a direct impact in events like this. And so when we use the term external blood loss, the difference is blood actually leaving the body versus internal bleeding when we start talking about cavities that come into the places. Blood leaving the body is something we can help stop and slow very effectively. Three primary interventions that we're going to discuss are direct pressure, pack and wrap, and tourniquet use, which is going to come down to limbs only. So when we start getting into junction areas, like thick areas like the hips and the shoulders, I can no longer utilize tourniquets. Those are going to be for limbs only. So if we look at direct pressure, it's exactly what it sounds like, putting pressure directly on the wound. And so if I have a gunshot wound in my leg, it's applying as much pressure as I can down into that wound. Now, this is going to help us by, imagine this is my hole in my leg, by compressing the tissue down and together, it starts to occlude and put pressure down where the actual break in that blood vessel is. And that's what's going to help to promote clotting, slow down the loss of blood coming out of the body, and start to get us on a path to safety. The deeper the wound is, often, the more bleeding. The more bleeding and the deeper the wound is, the more pressure is going to be required. So if you imagine, again, if we stick to this idea of a leg wound, the majority of the heavy bleeders are going to be located closer to the bone. And so superficial cuts and scrapes in the body may not require as much pressure because they're closer to the surface. And generally, those are more capillaries in certain areas and can be compressed and shut off because they have a lower pressure of blood coming through them. Well, if I start getting down into femoral artery, going near and down through the femur and all those areas, I have to compress all of the skin, fat, and muscle tissue that is in between my hand and wherever that blood vessel is. So in somebody that has, especially if they lift, so if they have strong legs or a strong upper body and that's where the wound is at, I have to put as much pressure as possible to compress that. So the deeper the wound, generally speaking, the more pressure is going to be required, and generally speaking, the higher level of intervention as well. Um, we lean or put weight however necessary. So if I can use my body to apply direct pressure to someone else, I will. If I can use my body to apply direct pressure downward into my own leg, assuming it's a leg injury, I will. If I can use another object and lay my body on top of it or lay that thing on top of me, I will. And that's going to be determined by what I have available to me and who I have available to me. The idea, keep it simple, put pressure directly over the wound, and it's going to hurt.
How do we know when we've put enough pressure?
Great question. The answer to that is with any intervention, you have done everything you can. That is the first piece of the puzzle, right? So put as much pressure as possible. And if it is continuing to bleed, then we're going to move on to another intervention, which we're going to discuss here shortly. However, if I'm utilizing all of the force and resources I have, then that's what I can do. So I'm at least slowing it down. The short answer to this thing is I do whatever is necessary until the blood stops. That's how you're going to know how much pressure. And so with direct pressure specifically, like think about it. If somebody punches me or if I cut myself accidentally, even like a paper cut, we immediately cover, we grab it or we stick it in our mouth because that's very natural for us. It's the same idea. So we get shot or stabbed, it's a larger wound. However, that same instinctive, intuitive response is important. Cover it as soon as possible and apply pressure. The answer is as much pressure as possible, and we continue intervention until we stop bleeding or run out of resources. Great question. Thank you for that. So here's just an example. These are some photos, images that we used for the book. You'll notice, so this is my leg and this is John applying direct pressure. John has stacked both of his hands over top. And what you'll notice is that his legs are off, or his knees are off the ground. And so what John is doing in this, from remember a concept standpoint, is he's applying as much downward pressure as he can possibly apply. Okay. If I am unable to push off of my legs, then I'm still trying to get as much of my body over top of that as possible. If I'm unable to use one or both of my arms, then maybe I'll kneel on top of that wound in some form to apply that pressure as well. And so the idea is to create as much leverage directly over the top of the wound as possible. So the next intervention that we're going to talk about is pack and wrap, packing a wound. Simply put, packing a wound is filling the wound channel, what we would consider where the bullet went, with some type of porous material. Now, we generally, our minds go to a medical type gauze of some form or fashion, and that is great. However, if I am unable to get access to that quickly, any woven cotton substance can be beneficial. So tearing clothes can be beneficial. Using towels, using paper towels, using toilet paper, something to shove into there to start to promote clotting. We want to fill that space as close to the vessel as possible. So by getting close to the vessel, we start to allow all the fibrin and things in the blood to start to create the mesh they need to do that. And secondly, by filling the area, now when I apply direct pressure, I'm actually applying more pressure because now I'm able to push through all of that substance that's filled that cavity and push more focally and directly into that wound. So packing serves as both promoting clotting and adding additional pressure, which is going to support our direct pressure efforts. Wrapping is securing that packing into place and adding additional pressure. Wrapping will more commonly with a staged medical kit look like using an ACE bandage to wrap that up, some form of an ACE bandage. You can even use some of the stretch and wrap tourniquets, which we will talk about a little bit later in this section. However, I've now packed the wound and I want to secure that packing into place. So I wrap something around it. From an improvising standpoint, I can use a jacket. Again, I can tear a shirt and use a shirt. I can use a belt. A belt can be used as a good wrap. It is not a good tourniquet. And we'll talk about that a little more later with improvisation with this type of stuff. But it can be used to help secure some type of a packing into place. And then I can apply direct pressure over top of that. So if we look, here are a couple of images to give you an idea. When we say, I apologize, I'm at my home office and my dog most likely sees a dog. When we say pack a wound, we mean pack a wound. So what you'll notice in this image is that John is driving this, in this case, what is rolled gauze. He's driving that down into the wound. So when we're talking about packing, most people's brains will go to, okay, cool, I put something over top of the wound. While putting something over top of the wound doesn't, negation acknowledged, fill the wound and get to where the actual blood loss is taking place. The analogy that we like to give is if you were to take a garden hose and turn it on and then simply put your hand over top of it, it's still going to spurt out and find ways to fill and backfill. However, if I were to take a washcloth and start to jam it down into there, it's a more effective way of stopping and backing the blood flow, or in that case, the water flow. So you have to understand, though this is very simple, it is a very simple concept. There's a hole. I'm going to fill that hole with a woven cotton porous material. It is difficult psychologically and emotionally because, as you'll notice, we're driving this down into the wound. So that takes me psychologically being willing to actually take my fingers and drive them inside of the wound of another human being. And then I also need to understand that if they are feeling pain, this is going to be a very painful process for them. So it is very simple, very simple. Underthink the entire process. There's a hole. I'm going to fill it as deep as I can and as full as I can with a woven cotton porous material of some type, preferably sterile medical gauze. However, I can improvise other areas. It is difficult psychologically because this is what we're doing, and we're shoving a hole filled with cotton material. So keep that in mind. When we look at wrapping, you'll notice right here that he's using, in this case, what's referred to as an Israeli bandage. It's an ACE bandage that has a hook so that you can actually create backwards pressure. Other than that, it's got a big old gauze pad on it on top. So it's an ACE bandage that's supercharged for mass hemorrhaging. And he's pulling it very tightly around that wound. He's going to wrap it, secure it on the other side of that. And then, if I'm the only person he's addressing and dealing with, he'll most likely also apply direct pressure on the back end of that. And that's why, again, I'm putting another direct pressure slide image in here, which is right over top of where I packed, wrapped. I'm going to go right back into direct pressure again to just double time my interventions for blood loss. So if we start talking about tourniquets, this is where things get, there's a lot of misinformation about where tourniquets are at. We are going to keep this very simple. We are going to address it in the healthiest, safest manner. And the one thing I want you to understand is, yes, this will require a little bit of training. However, it's a very simple process moving forward. So tourniquets slow or stop blood flow to a limb. Where on the limb depends on where you place them. There's essentially two procedures to applying a tourniquet. One can be to locate it roughly 2 to 3 inches above a wound. So let's say I'm shot here on my bicep, I would go 2 to 3 inches above it. If I was shot down here on my forearm, I'd go 2 to 3 inches above it. The caveat with that is we avoid joints like the elbows and knees, especially. So it has to be on some portion of the limb. So if I'm shot in the forearm just below my elbow, then I'm going to actually place the tourniquet 2 to 3 inches above the elbow. So I'm staying off of that elbow joint. So that's one option. The other one is what we refer to as high and tight, which is if I'm shot multiple times in the arm and it's bleeding from all of them, or I'm just uncertain about my ability to get 2 to 3 inches above, I'll simply go high and tight on the arm and shut off all of the blood flow to that limb. Now, one of the questions that comes up is, are they safe? And the reality of it is, yes, if applied properly, as quickly as possible, and with a reliable, proven tourniquet, they are very safe. They're used all the time by our military units overseas. They're used by law enforcement departments and SWAT departments in the middle of action. And they're used now by medical professions on a very high level for gunshot wounds, blast injuries, extreme hemorrhaging, and open dislocations, large breaks. And the same exact protocols that we're going to be looking at, which is if you know how to apply that tourniquet quickly, do so, do it how the manufacturer created it to be done, and you're going to be well there. If you want to dive a little deeper, there's a great study from Lee Porter and Hodgetts that was actually released back in 2007. And one of the findings they had is that if the tourniquet is on for 2 hours or less, in almost all cases, there was zero nerve damage and zero additional damage to the limb. And in the state of Ohio specifically, 2 hours is a very long time, as we usually have level 3 trauma centers within a life flight of 15 to 20 minutes, right? So that becomes more important from a statistic standpoint when we start talking about I'm in the desert and I'm not going to get back to base for 4, 5, 6 hours in some form or fashion. Um, Even in the instances of where we have it on for longer than 2 hours, we then go back to the conversation Marley and I were having, which is I can bleed out from massive hemorrhage and possibly lose my life now, or I can apply this tourniquet and the potential to have nerve damage or an amputation down the road. And that's a moral and emotional decision that each individual gets to make. However, we want to make sure that we understand that perspective. If the tourniquet doesn't go on, I may bleed out and die in this case. And so it's about the pros and cons and understanding where we make that decision moving forward. Now, there's two different styles of tourniquets. The ones that we recommend are what are usually referred to as windlass style tourniquets. They are applied and cranked. I'm going to show you a video here quickly of how to do that. The other ones are referred as wrap style. On the windlass style, the proven manufactured tourniquets that are used most widely by military, EMS, and police are usually referred to are the CAT tourniquet, CAT, and the soft tourniquet, SOFT. They stand for Combat Application Tourniquet and then Special Operations Forces Tourniquet. They're both very simple to apply. You can order them from reputable organizations. They run about $30. We'll talk about med kits a little bit later. The other style is the wrap style tourniquet, which we'll talk about as a SWAT style tourniquet. And so this is an image. I'm going to show you a video as well, but this is an image of John applying a tourniquet to his leg. And now this image specifically, he's in a standing position. However, realistically, if he had traumatic injury to his leg, and you'll see here shortly in the video, we learned to do this from a seated position, because if I have traumatic injury to my leg, it is unlikely under all context that I'm going to find myself comfortably standing in this position. The reason we did it here is we get a better visualization of what John is doing to apply it. He's pulling it as absolutely tight as possible. You'll see here in the video a little bit later, he's going to pull this strap down and lock it in, which has double Velcro on it. And then that big rod that you see, that's the windlass. So once we pull and apply the tourniquet as tight as possible, we're going to crank that windlass until the blood stops. And so that's going to be how you know you cranked it enough. You turn it until the blood stops. It'll then secure in that little C clamp. If you can see right behind the rod, it looks like there's the two openings that hook like this. It'll secure right in there so that it stays stable and secure moving forward. Here is another image of him using it on his arm. And this, again, is something that we're taught and trained to do, to be able to apply our own tourniquet or apply it to someone else in any perspective, to an arm or to a leg. And in both of these situations, he's doing what we refer to as that high and tight situation. This is what a wrap style tourniquet looks like. It's a big, if you want to look at it, it's like a big rubber. It almost looks like the inside of a bike tire, but it's flat and it's wider, and you wrap it and wrap it and wrap it while continually putting compression. It's a little more cumbersome to apply, especially to yourself and especially under stress. However, they are easier to carry, and that makes them favorable when it comes to a civilian carrying around a med kit, because they're very slim. It's if you're carrying one of these around, it's less than the size of a deck of cards. So I have a little med kit right here, and this would be a SWAT application tourniquet, which is what you're seeing right there. So I have a video here real quick that I'm going to show you. We're going to fast forward through a big chunk of this so that you can see.
Generally considered proper tourniquet placement as far as location is 2 to 3 inches above the wound.
which we discussed.
After I've done that, I'm going to take this rod here, it's called a windlass, and I'm going to turn this until I notice that the bleeding has stopped. Now, it might take a second or two with the residual blood that's in there, but if it's actively flowing or spurting, you should see a relatively quick stop.
So that's him applying it to his arm. This is him now in a seated position looking at applying it to his leg.
Through the buckle. And again, this is going to have to be as tight as I can before I touch the windlass. Then I'm going to go ahead and turn the windlass. Might take half a turn, might take a couple turns.
That's him applying it to his leg. And then the last one that we're going to look at is one example of applying the SWAT tourniquet, which is a little more cumbersome. And you can see how this may pose a problem to try to wrap onto your own arm as you're trying as hard as possible to actually get compression and wrap on that. So they're very versatile. They are very versatile. They're relatively easy to apply to your own leg, or I should say easier. However, applying it to myself and an upper body, if I'm going to do my upper limbs, can be quite cumbersome. Check the chat box here. Oh, can't hear. I apologize. So it's okay that you couldn't hear it in that perspective. What he was saying in both of those was he's pulling the strap as tight as possible, and then he's spinning the windlass until the blood stops. And then from there, he's just simply locking it in. And the same thing, upper body, same thing, lower body. As that goes, you pull it as tight as possible, and then you crank the windlass until the blood stops, and then you lock it into that position. And so that's what he was running through there. And I will find a way to make these videos accessible to y'all so you can go back and look at it. You can also check out John's website at immediatecasualtycare.com, and he has a lot of resources for civilians as well to dive deeper into that. So thank you for pointing that out, that the audio wasn't too great on that. So as we move forward, that's taking care of massive blood loss. All of those interventions are very simple, especially when you get yourself a chance to practice and train with them. And we can talk about resources for training moving forward after this, maybe in the debrief section. Direct pressure as soon as possible. If I have access to a medical kit, then I want to access my medical kit. I'm going to pack the wound. I would prefer to pack the wound over simply direct pressure and then wrap it and then direct pressure. If needed, if there's a massive amount of blood loss, and you'll know there's a massive difference between psychologically like, oh, wow, that's blood, and, you know, excuse my language, but holy shit, that's a lot of blood under stress. And in that case, in that, like, wow, it's spurting blood and it's coming out. That's an instance where I'm going to go directly to applying a tourniquet if, and this is important, if I have one accessible to me. And so now that we've gotten ourselves out from the limbs, we're going to move ourselves into the cavities. Now, one area that we can be significantly helpful in is in a chest wound. And now the primary concern with the chest wound, the primary concern that we can address is pneumothorax. That is a fancy word for my chest cavity is pressurized. It's the exact pressure that it needs to be so that my lungs can expand. And when they expand, they draw air in, right? And then when they compress, they push air out. Well, there's the exact amount of pressure in my chest cavity to allow the organ to do that, to allow the lungs to move the way they want to. Well, if there's a penetration in the seal of that, so if I get hit and it goes, you know, through the flesh, through the muscle, and into the chest cavity, now what happens is if air and fluid can move in and out of that chest cavity, the pressure inside of the chest gets actually over pressurized. So as air from the outside, which is a higher pressure than the air on the inside, starts to push its way into the cavity, it makes it harder and harder, puts more weight and compression down in the lungs, and the lungs are unable to actually expand. And if they're unable to expand, they can't pull air in. And so that's a huge problem. And in this case, you'll suffocate before any blood loss issues in that perspective. And so our job is to re-put and repurpose the seal, right? There's going to be, when EMS gets here, an ability for them to decompress the lungs. Our job is simply to stop the impact from becoming any worse. And so, the analogy I give people is legitimately right out of the gate, you can think just the Dutch boy with his finger in the dam, which is like, oh my gosh, like I notice maybe they're having trouble breathing. I notice there's a hole in a shirt. There may not be outward obvious external bleeding with a chest wound. And so I can go, once I find out and identify, oh, wow, there is a chest wound and an issue here, whether it's from trouble breathing, things like that, I can go in and I can actually block. I can stop that. I can shove a finger. I can put my hand over top of it until I can access a higher form of an intervention. Now, in a staged situation with a medical kit accessible, we would be looking for what's referred to as a chest seal. A chest seal, I've got all my medical kits here so you guys can see a little bit of what this stuff looks like. A chest seal usually comes in little packets like this. Okay. And now there's two for a reason. We'll talk here in a minute. I would tear this open, and inside of this is a piece of gauze and essentially a sticker. Now, it's a sticker that serves a very specific purpose, and that is to cover and seal over the top of it. So it has a very high level adhesive, medical grade adhesive, and some other things on it. I take the gauze, I expose the shirt, I wipe away any debris, blood, fluid, and then I peel the sticker off and put the sticker placed centered directly over top of the wound. That's it. That is how you apply a chest seal. Once we've done that, we've refined and replaced the integrity of the seal around the lungs, and we've again bought them time for EMS to get there, and then they can use things like decomp needles and things like that to then do further intervention. Our job, our duty is to stop that situation from becoming any worse. And chest seals are a great way to do that. And they're, again, very simple. They simply seem out of our pay grade. That seems like something that we can't do anything about, where we can actually do a lot with it. If I am unable to get access to a chest seal, I can actually use anything occlusive. So plastic, a sandwich bag, technically a credit card, and some duct tape can be used there. Preferably, I would have something that's meant to be there, which would be an actual chest seal. So these are a couple, again, images. You'll notice in this image, John is using the gauze to wipe away what would be an imaginary wound. In his right hand is the sticker that we were talking about. And so it has a big red tab on it so that you can easily identify where to peel it. It's a big red tab. It peels off. And then he applies it and flattens it essentially from the inside out. We want to make sure that it secures and adheres to the chest with flat without any bubbles. So we place it over top, centered over the wound, spread it out nice and flat. Now, one of the things that I said was these generally come in packs of 2. And the reason is if I have a bullet wound through my chest, there's the possibility of an exit wound. And that means that I could have a hole through the chest and a hole through my back. And in that case, I may need 2 chest seals to restructure that seal. And so in this next image, you'll notice that he worked on the chest, got the chest seal on it, and then was able to roll Dante towards him, who's the one posing in this image, and then start to work and secure that wound wherever that exit wound would come into play. And so that takes us back to our body checks. I would body check. We've discovered an issue. We put on our chest seal, and then I'm going to do an additional body check. I'm going to roll them over to their side, expose their back, and I'm going to check with my hands, with my eyes, with my ears, even to hear any gurgling or air moving in and out. And then that's going to identify, okay, there's a second wound I need to deal with. I can either cover that with my hands, use some type of improvised option, or if I have a secondary chest seal, I can use a second chest seal as well. So again, it's a very simple, it seems way out of our reach. However, it's a very simple application with a little bit of training and some good staging. Now, when we talk about head and abdominal wounds, this is where things start to absolutely get out of our pay grade. We have to understand that head and abdominal wounds are very high risk, and they also require intervention that uh, um, we are generally not equipped to handle. Even EMS, when they show up on site, are a little less equipped to deal with this stuff as well. Like massive abdominal wounds and injuries, there are obviously certain things they can do that are above where we're going to be at. However, at some point in time, if I have internal bleeding, I need to get to a surgeon to find where that blood loss is coming from and stop that blood loss. And so with head trauma, you're looking at light pressure, taking a towel, gauze, something over the wound, whatever it is, depending on how severe the wound is, to keep that very light pressure. And then, if possible, keeping them upright. And where I say if possible is if you know first aid protocols, if I have the possibility of a head, neck, or spinal injury, we don't always want to move people. And so if they're lying down and I think there may be an issue there, then okay, maybe I'm not going to pick them up. By picking them up, what we're doing is we're slowing the pressure upwards. And so that's going to slow the amount of actual blood that makes its way out. And so that's one possibility to get into. Head trauma is very severe. It's very high risk, and it's going to be something that there is minimal we can do. However, these are the things we can do to help. Abdominal wounds are very much the same. With abdominal wounds, especially if they're big open wounds, the biggest thing that we can do is cover that wound and keep the person warm, because them losing heat out of the inside of their body, whether it's through bleeding or an organ being exposed outside, is the biggest thing. Them going into shock is our biggest concern in that perspective. So there's really not too much I can do in there. Cover the wound up, keep the body wound, and apply moderate pressure if it's a smaller wound in that point. Here you'll see an example. This is one of the scenarios we ran at our facility. So this is the attacker's already been taken down, and now we're doing medical intervention for anybody that's in there. And Dante in this example was posing as somebody that had a gunshot wound to the abdomen. And so simple light pressure, moderate pressure. You notice he's slightly pulling back as opposed to putting himself over top and applying everything in there. Your abdomen's a big squishy area, so there's nothing to push against like the bone. So it's moderate pressure. It's not huge, direct, heavy pressure. So as we continue, the last two things that we're going to talk about are airway and shock issues. Now, in most of these cases, airway issues are going to come from the way people fall. So if I fall over and my chin is down compressed, it restricts the ability to breathe. So in most cases, the answer here, or the main focus in our evaluation of the body, is head tilt chin lift. If I'm lying there, I want to get to a position where I open that airway up and allow them to naturally and normally breathe on their own there. Things like having to do mouth swipes and having to give CPR are going to be more extraneous situations and are more rarely seen in these events, as opposed to someone was shot, maybe lost consciousness, they fall over and they're hunched and shutting off their own breathing. So we want a head tilt chin lift. That's going to open up the airway in most cases. With shock, keeping the body warm, you can get into really deep woods if you really want to understand shock. The first thing I do to make sure that or to help against shock is going to be stopping massive blood loss. The body will go into shock more commonly if it's having massive blood loss. So I address blood loss. It's the reason we get there first. After that, no matter the level of trauma, we want to keep the body warm so that all of the things inside of the body can function the way that they're meant to be. That's why, generally speaking, in any emergency situation, like blankets are the thing that come out, no matter the trauma level. And so right out of the gate, I want to keep the body warm, and I want to try to keep myself or the other person alert, either through questions, dialogue, eye contact, as much as possible to keep them focused on staying in the moment, staying conscious in that idea. And so when we start getting, you can notice blood loss, tons of stuff we can do. Chest wounds. Okay, we've got something that we can do here. Now, as we start getting out, the interventions become very simple one-way streets that I can add on and buy time for them to then be addressed moving forward. So we then repeat. We go right back up. Is there anyone else that needs medical intervention? Identify any other injuries and then address those injuries. Check to see if anyone else needs help. Recheck the interventions that you did and continue that process until you're able to hand them off to somebody at a higher level of prevention. The last piece of the puzzle that really goes into this is communication. Remember, those of you that joined us on Monday, I like to look at everything from an individual response standpoint. If I'm individually responding, then I can take care of myself. However, other people are the icing on the cake if they're willing participants. And so in an event, recruit other people to help you. If I want someone to call 911, tell them. Not, hey, can someone call 911? It's you. Get your phone. Do you have a phone? Call 911. Get them here. Give them this information. Give direction on what to do. If I'm injured and we don't have access to a medical kit, or I know the medical kit's down the hallway, I'm applying direct pressure, hurry up, run, second door on the right, there's a medical kit, grab it and bring it back as soon as possible. So I'm able to now do 2 or 3 things at once. Be short and direct with any commands that you give, especially in those moments. Under stress, short, direct commands are the ones that will take over and get action out of people. If there's a lot of ambiguity in the way that we talk, there's going to be a slowing of the intervention process, and we want this stuff to take we want to take effect as soon as possible. Take charge if needed. If no one else is giving you help or giving anyone else help, start again being short and direct with commands, advocate for yourself, give yourself that support. And then the other leg of communication is I want other people to understand how to do these things as well. So again, all the people in my life, I now have an idea. Hey, I attended this amazing, or I'm assuming amazing presentation on trauma care. I want you to understand how this works as well. We're going to get a medical kit and we're going to practice and train with this medical kit and get other people involved. The more people involved, the better our likelihood of increasing our intervention and saving lives. Very briefly, I want to talk about improvised versus prepared. The reality of medical intervention is that I can give back, or I can give care based off of what I have access to. And so even when it comes to a medical kit, if I have a medical kit down the hallway, but I'm shot here, that medical kit isn't doing me any good right now. And so what can I do right now to then get to the medical kit, then get to the medical kit? And so we want to be able to have things as close to us as possible, whenever possible. And that allows us to look at a couple of different things. So preferably we want to have a supplied medical kit, which I'm going to give you a couple examples of here shortly. 2 questions. How quickly can you access it? And then what is the difference between it being on my person, on site, which means, okay, at least in the vicinity, and then far away, and how I would access those type things. To give you a real quick example, so this is a medical kit that I have in my truck all the time. I'm a self-defense instructor and also a firearms instructor. So this serves many purposes. If we're in a car accident and my family needs any assistance or anyone else needs any assistance, this kit has enough stuff in it to take care of myself and multiple other people if necessary. It's in my truck. If I get shot inside of my training facility in Columbus, Ohio, this isn't doing me any good, even though it's a very well-stocked, supplied kit. So it serves a purpose in the context of my vehicle and in the context of when we go out on a shooting range and I'm educating people on firearm safety, having this accessible to us. We bring it out on the range. This is an ankle kit that you can either place on your ankle, or the way that I use it, I actually have this attached to the strap of my backpack that I carry everywhere. It's got my computer and everything that goes in it. And so this one is more likely to be in closer proximity to me when I go places in my truck. If I fly somewhere, then I will most likely also put this on my ankle and actually have it on my person. So now it's actually on me. So that's another medical kit option. This one is, it looks very, very slimline and simple. Inside of this kit, I have a SWAT tourniquet that we talked about. I also have, if you can see in there, combat gauze, which is a form of gauze we'll talk about, and then flat pack duct tape. This actually attaches to the waistband of a pair of pants, and you can wear it inside the waistband. It's barely noticeable, super comfortable. John Grabo from Immediate Casualty Care actually invented this. And I can carry and have something on me always. And so again, that's going to be more beneficial than the thing that's, far away from me. So I need to know what resources I actually have available to me at any given time. If I don't have planned and prepared things, then I can start looking at improvising if necessary. So for instance, we talked about this earlier. If I need to pack a wound, I can use shirts, towels, paper towels, toilet paper, pretty much any porous woven cotton material. If I don't have access to a chest seal, I can use my hand, I can use duct tape, I can use plastic to help. We would prefer to have it. Both styles of intervention require training. So again, we finished this presentation. This is an educational presentation. We want to take this one step further. We want to buy the equipment and we want to actually train with it. So I'm going to give you a quick look. We're running a couple minutes behind, so I'm going to do a quick snapshot on this. However, you do have access to these slides, and so you will be able to see this. And then you're also going to have access to the book, which really dives into building a trauma kit. And so I'm preparing for medical emergencies. This is useful for car accidents, work accidents. I had a friend a long time ago that fell off of his roof and landed on a steel rake, and it punctured into his hip, and he had massive blood loss and a fractured pelvis. And this is something that had his family been prepared with this information and been privy to this information, they would have been able to buy him some time. He was fine. Very luckily for him, medical got there with 3 to 5 minutes. However, very, very helpful. I have another friend in Texas that witnessed a car accident where a young lady was ejected out of her car, and she had a broken femur and an open dislocation and had severe hemorrhaging. And he's a firearms instructor as well, and happened to have a medical kit in his truck. And so he grabbed his medical kit, applied a tourniquet, and the ambulance, when they showed up, absolutely accredited him with saving the girl's life, having enough time for them to actually get there and help. So it's more than just getting shot or getting stabbed in a violent encounter. The different options we can talk about that I like to have covered on your person, in a vehicle, one that you frequently are in your home, and at your work. Where are my trauma situations or trauma measures in those areas is a nice place to start looking and to build things for. Your primary components, and I'm going to show you a specific template of how I would build it out, are gauze, pressure dressings, tourniquets, and chest seals. And we'll look at some specific options. And then as far as pre-put together medical kits, Immediate Casualty Care is a great option. Dark Angel Medical is a great option. And then a company called North American Rescue is also a great option. One thing to keep in mind is there are knockoffs for some of this stuff. So stick to like these primary brands, especially the brand North American Rescue. They make and actually produce and manufacture a lot of the actual implements. So they manufacture these, North American Rescue, the chest seals, things like that. If you see a tourniquet on Amazon for $20, a cat tourniquet for $20 and one for $35, buy the one for $35, because the knockoffs will most likely break and tear on you, which is a very bad thing to have happen to you in a situation like this. So here's your template. Have a small bag or pouch that easily opens so that you can see exactly what you're getting into and makes things visible. Have at least one thing of gauze. You can have Z-fold, rolled gauze. Combat gauze simply has what's referred to as a hemostatic agent in it, so it promotes clotting. It is expensive. It's like $50 for one packet of it, whereas for $50 I could buy 5,000 yards of rolled gauze. So it really just comes down to what you want to have access to and be applied to in your circumstances. A pressure dressing, which can be an ACE bandage. It can be an Israeli bandage, which is just an ACE bandage with a gauze pad attached to it and a hook. One chest seal. NAR stands for North American Rescue, which I mentioned before. And then one tourniquet, preferably a cat tourniquet or a soft T tourniquet. And then you can also look at that SWAT, which stands for stretch, wrap, and tuck. That's what SWAT stands for, if you were wondering. So that's your basic template for making a medical kit. And then I can expand on that by size, right? So this obviously I had one thing of gauze. I had a tourniquet that also serves as a pressure dressing, and then duct tape, which can help me serve as a chest seal. In the ankle kit, I had a SWAT tourniquet. I have a cat tourniquet. I have 2 things of combat gauze and 2 chest seals. So there's more stuff in that one. In my larger kit, there's multiple tourniquets, multiple chest seals, multiple ace bandages, and a bunch of gauze. I also have some other implements in here. And then I actually have a mass trauma kit, which is this very large bag that has upwards of 10 tourniquets and everything past that. So I can go farther and bigger. At a minimum, this would be what you were looking for template wise to build yourself a medical kit. And we already discussed this: car accidents, work accidents, home accidents. This is important stuff to protect yourself and your family. So the last piece of the puzzle that I want to get into is interacting with responding units. And to me, this is super important because if we are unaware of what's going on, it can become very frustrating, especially in an emotional event like violence and self-defense. We're already upregulated. Our nervous system is very high. And so we're very hyper focused on ourselves and our survival. And it can be very frustrating when we find ourselves in what become the protocols for responding units. And so I want to discuss this briefly to give you an idea what these look like. And then I do want to make sure that we have about 15 minutes to answer any questions moving further. So first and foremost, when you're calling 911, we want to, for the most part, narrow things down to descriptions and locations. Description and location of bad guy, description and location of good guys. And when we look at this, we have to remember that our objective is to get them to us as soon as possible. And so when we're under stress, we like to add additional things to it, and it's understandable. However, if I call 911 and I'm immediately going into, he has a gun, I'm scared, please come help me, I'm scared, all those things, which are legitimate concerns. However, the longer it takes for the dispatcher to get the necessary information to actually dispatch units, the longer it's going to take for those units to get to us. And so if we can learn and train to immediately get down to descriptions and locations, there is a shooter at the, let's say it was at my facility. There is a shooter at Endeavor Defense and Fitness in Hilliard, Ohio. There are multiple people injured. The address is 5040 Nike Drive, Hilliard, Ohio, 43026. We are locked in the front office, right in the lobby. The shooter was last seen in the back room. Like, I'm getting right to the information they need to transfer to the units to get the units there. The longer it takes to get that done and the more excess information I give, the harder and longer it's going to take to get help. And so that's a tough ask. That's a tough thing to do when we are panicking and upregulated. And that's again where actually practicing 911 calls, faking them, pick up a phone, act like I'm calling 911, go through a script in my head of what that may look like. Getting that practice in is super important to help get things there faster, because every second genuinely counts when it comes to events like this. So descriptions and locations are really what they're looking for. And immediately it's about stopping the threat, which we're going to talk here in a minute, versus helping individuals, which we're going to talk here in a minute. One thing we want to understand is we want to be specific and general. And I know that seems counterintuitive. What I mean by that is we want to be specific about where things are taking place with as much information as we can. However, I need to remember that it's most likely that these law enforcement or EMS ambulance have never been in this building before. So if I use terminology that is only in the semantics and the language of my building, that can be a problem, right? So down the hall, third door on the right, it's like, okay, well, what hallway, right? Or we're in the back room, and it's like, okay, what you imagine to be the back of the building may not look like the back of the building to me. Or when I get into the inside of the building, I may not understand where the back is at or how to get there quickly. So using things like cardinal directions, north, east, southwest. I'm in the northwest section of the building, locked in conference room 604 on the 6th floor. That's very specific. Now they know exactly where you're at, where things were located, and they have identifiable markers. They have floor levels that they can look at. They have cardinal directions as they're approaching the building. So things like that. Be specific and also speak in common terminology. One thing we need to understand is police's primary job, law enforcement, when they show up, is to stop the killing. And that means to get to the threat. So we get to understand that when law enforcement shows up, their job is not to save Aaron Janetti. They are not there to help me with my gunshot wound. They are there to stop the threat. We stop the killing, then we stop the dying. And so we need this to take place, or else the body count gets larger. And so their job right out of the gate when they get there is to find the threat as absolutely quickly as possible and neutralize it. And as they're doing that, they're also combating the possibility of multiple assailants. They're combating misinformation. So they can get, for instance, if we look at the Ohio State University incident that took place a few years ago, where the student wrecked the car in front of the building, got out and started lunging at students with a knife, right? So that individual was shot down within approximately 90 seconds of the event taking place, because fortunately there was a law enforcement officer that was responding to a gas leak situation that was going on. However, 911 dispatch was receiving different descriptions of a shooter when there wasn't even a gun involved. So there was a car crash followed by a stabbing, followed by gunshots from the law enforcement officer to stop and neutralize the threat that wasn't stopping. Well, all of the 911 calls were for an active shooter. So they're working off of information they're getting, and they're assuming based off that information, okay, we have to do this, we have to do this, we have to do this. So at one point in time, for an event that was over within 90 seconds, they had gotten information about 3 suspicious bags that could be explosives. They had gotten information about multiple descriptions of shooters in different locations on campus. And they had also gotten information on who the attacker was and where family members were and issues that may arise there. So you have multiple departments that aren't necessarily used to communicating with each other, arriving on a chaotic scene with a massive amount of information coming from different areas that they then have to sort through and figure out. And that's very complicated. It's a lot more difficult than we normally imagine when going like, oh, cops are going to get here and put the guy down. Well, they still have to go find the guy. They still have to go find anybody that may be an additional threat or matches descriptions of additional threats and work their way through all of this. Then they get to slow down and go through their secondary job, which is collecting evidence, supporting people that are injured, and then also trying to figure out what happened and why it happened. And so it's really important to understand their duties and how it's going to play out. And so for law enforcement, it's going to take place in 2 different sections. The first is going to be the fast search, which is find and stop the threat. In those cases, our roles are to give information if we have it that is helpful, keep hands visible so that they know we're not a threat, and listen to any commands that are given. And again, in the midst of an event where I'm worried about my concern and safety, that may seem very counterintuitive, very much like you're here to help me, please come help me. However, by keeping our hands visible, listening to commands, and only giving them information that is helpful to them, we resolve the situation faster, which means indirectly we will receive support faster. So it's really important for us to understand why we act this way when law enforcement gets there, which is act non-threatening, clearly show your hands, which can be threatening, listen to commands, and only give information that helps them find the threat in that position. And that's an important place to be. With the slow search, they're then confirming safety. So this is going to take longer. They have to clear all of the rooms. They're going to interview and identify a lot of people. They're most likely going to ask most of the people on site to go to a certain, what they would consider safe place and debrief them. Anybody that's injured, they're going to work towards making that area safe so they can then get EMS on site. They're then going to want to go interview all of those people, which takes time. And so we have to understand this process is in place for a reason. It can seem very inconvenient and at times seem very discomforting. However, it's there for a reason. If we understand why it's there, we can then help the process as soon as possible move along quickly. So we always want people to know the slow search can take time. The situation at Ohio State was over, like I said, within 90 minutes. However, the last witness was released approximately 4.5 hours later. So by the time they did slow searches, debriefs, and everything else, and there was a lot of miscommunication that happened as well. That's a long period of time. Empathize. They're there to help. Oftentimes, they're trying to process data just like you are. And remember, when they get a call, you're in the midst of it, which is stressed out. They have, they also have the anxiety and the rev up and the adrenaline of like, I am moving towards a threat in which I'm technically kind of required to go after that could absolutely end my life. And so they're stressed out just as everybody else is. If you're going to give information, keep it very simple, right? Be prepared with locations, timelines, if you have them, descriptions, be very direct about it. If you don't have information, look, man, I didn't see anything. This is exactly what happened. I went here. This is went boom, and I went to that position, and that'll speed that process up. Adding in our back end to it of why is this taking so effing long? I didn't can see anything. All that type stuff makes the process longer and harder and slower. And then understand that this is emotional for everybody. And so the more we can support each other in these events, the better that it's going to be to move things along quickly.
I have a
Now we want,
question.
I
Aaron.
love questions.
For those of us who have disabilities right now,
Mhm.
we're in that situation. Police officers are giving us commands. Is it safe for us to consider it a given to say, I'm a wheelchair user, I cannot go down the stairs that you just told me to go down? I'm visually impaired, I need someone to physically direct me to the exit. Um, would you say that that is pertinent information in that moment to help them help us and those that are still in danger?
That is a beautifully brought up, and thank you so much for bringing that up. Um, that is huge, and that goes back to the importance of communication, the importance
Mhm.
of knowing these in advance and using simple, direct, clear commands. And so absolutely, if a law enforcement officer is, again, and they're in their own stressed out mind and state and they're going, you guys move this way, move that, whatever that is, then yes, absolutely either say, I'm a wheelchair user, I cannot go down these stairs, what do you want me to do? Or, I'm visually impaired, I need support. And that can then give them an opportunity to give you something else from another command standpoint. Now, I am going to be one of the only people that will, not only, but I will say that there are very few people that are going to give you this next piece of advice, which is in the event of a disability or something that another person would have more difficulty relating to, if the information given to you is inaccurate or possibly unsafe, and you have determined it is inaccurate or possibly unsafe, then you absolutely need to vocalize that. And even if you don't vocalize it, as long as you are not being threatening, I would still advocate for my own safety. And so one of the examples that I would give is if I'm in an area and a law enforcement officer tells me to lock down in a room and stay secure, however, I can escape through a window out of that, I don't want to be there. And so for me, I would advocate for myself. I would continue to get to safety. And even though they would say, stay in this room, whatever, if I've decided and determined that I'm actually safer by moving elsewhere, my safety is my responsibility. And as long as I am not a threat to the law enforcement officers and don't pose any visual threat, I would still advocate for myself in that position. So I really appreciate you bringing that up, because that is a super important piece. And I love that we can add that in. And so having clear direct commands and communication for yourself in those instances should absolutely be something that we can evolve this type of training into for a situation with a disability, and that's beautiful.
Thank
And
you.
quick question,
Mhm.
kind of, I guess, taking Marley's question one step further, would it be pertinent information to disclose that to the 911 dispatcher that there is people with disabilities there?
Yes, and the there's two orders to the 911 call. And what I mean by that is, remember, in the midst of the activity still going on, the most pertinent information is the information that gets the threat stopped. And so in the initial 911 call, if the threat is still going on, the majority of descriptions and locations should be about, this is where the bad guy is, and this area is secure and full of good people. Just don't come in here. And in that context, uh, um, there's less need for the understanding of the different circumstances. And that's also, you have to remember, like if you're in a room and you're a wheelchair user and you tell the 911 operator, hey, I'm a wheelchair user and I can't relocate to that information, they may not, the law enforcement officer on site may not know what room you're in and when and where that applies. And in his mind, he's still just getting where he's going. The majority of commands, to give everybody a little more insight into this, the majority of commands you're going to get from law enforcement officers during a fast search, when there's still a threat, is going to be stay where you're at, lock into there, or go that direction. And then they're going to keep going. And what's going to end up happening is, if you imagine, this may be a good image for everybody. If you imagine lines of this, right? So the threat's here, and as law enforcement's entering, you have your search teams, whether it's an individual or it's broken into smaller units, and they're going in first. And once they've cleared an area and decided this area is not a threat, they're going to move into the next area. And now the next group may move in. And that may be a specific group of law enforcement officers that are meant to then go support medical staff or other people to work them out. And then as that next area is good, so little by little, you have the initial people going on the hunt, the people that are there for support, then EMS coming back. And as that scene becomes more and more safe, you're going to be handed back to the next level of communication. I imagine that was a little better way for you to imagine how this is working out. So in that initial 911 call, all of the information really should be directed towards that first group of units getting there. Where is this guy at? How do we stop the threat? Once the threat is neutralized, I can stay on the line with 911 or recall 911 or talk to the next group. And now, yes, that is absolutely pertinent information, because the second line, and that's where we're getting now, which is EMS, the hierarchy of help, is how do I now give information, descriptions, and locations of good people and injuries to the EMS, to dispatchers, so they know where to go as soon as possible. Did that answer your question, Jamie?
Yes, it did. Thank you so much.
Awesome. Thank you for both of those questions. Those are beautiful. So if we look at EMS, this is the last thing we're going to get into as far as this last piece of information. Now, remember, they're going to move when the scene is generally considered safe. Now, we do have very small groups of what are referred to as like tactical medics that are usually attached to SWAT teams that are trained in both how the law enforcement does things and then also EMS. And so they may go into more hot scenes to help people. However, we're talking one person, maybe up to 5 in a very large event, where if I have 20, 30, 40 gunshot victims that are spread out across an area, that one person is only able to do so much as they go in. So in mass casualty events, you have to understand the hierarchy of help, or we get to understand the hierarchy of help. And that is, the first people on site are going to start identifying injury levels and tagging them so that everybody else can be identified. So if I'm a medic and I'm the first one on scene in a mass casualty event, let's say there's 10 to 20 gunshot victims, Or take it an even higher level. And now imagine the Las Vegas shooting situation as medics are responding to that. If the first medic goes in and only goes to the first gunshot victim, they may be missing the huge picture. And so the first one's on site. They're going to be moving around. Can you get up and move? Yes. Move that direction. Can you move? Yes. Move that direction. You're perfectly fine. You're going to be fine. You're going to be fine. This guy is critical. They're going to put a red card near him. They're moving. This person has severe head trauma. They're probably not going to make it. There's going to be a black card. And what they're doing is, as they're going in and identifying, now the medics that are coming behind them can go out and they're going right to the red cards to give rendered immediate care as soon as possible. And they're moving their way through the red cards and getting them the help that they need as fast as they can. And then they're coming back through and addressing then the rest of it goes there. The ones that are yellow that are, I'm shot in the arm, I can still move, then go move to safety. We've set up a block over here, go move that direction. Here's improvised medical care. You apply direct pressure, hold it. He's going to be good for a while. So that's going to be what the event looks like. And again, that can be frustrating if somebody walks through the door and I'm shot in the arm. And to me, that's a shock. That's a huge shock. And adrenaline's going, and emotionally, I'm invested in my survival and my safety. And then the medic says, looks at it and goes, "You're good, hold that," and walk that direction, and leaves you. That can be tough. However, that is exactly what needs to happen to help this event go and move smoothly and safely. Because if you can apply that pressure and either use your wheelchair to get out, or use your walker to get out, or you have somebody to support you to get out, or you believe that you can get out on your own, then move that direction, advocate for yourself. You'll see one of the things I put down here is we want to understand resources are limited. And so if I can help myself, I want to help myself. If I need assistance and support, I want to advocate for myself and get that support, whether it's verbally. So now if I'm lying on the ground and I have a gunshot wound to the arm and they say, "Oh, that's not bad, get up and move," and I'm a wheelchair user, and I go, "I'm a wheelchair user, I can't move. My wheelchair's over there, I can't get into." Oh, shit. Okay. Next guy coming through is going to grab you, or, "Okay, stay tight. Let me check this room and I'll be back to support you." I'm advocating, I'm using those words to let them know. So that brings us to the end of this. As a recap, our safety is our responsibility. We want to focus on what is possible. We talked about the difference between first aid and trauma care. We talked about civilian use and using it in the field. We go through that immediate casualty care process, and that breaks down into identifying injury, staying as safe as possible, keeping the blood in the body through direct pressure, pack and wrap, and tourniquet usage. We discussed chest seals and chest wounds. We talked about head and abdominal wounds. We discussed the basics of airway and shock, at least in most cases here. We talked about communication with others, improvised versus prepared medical care, the idea of building a medical kit, templates to do that, the idea that this is still very good and should be available for everyday life. We talked about calling 911 and focusing on descriptions and locations. We discussed police, and that's fast search and slow search. And then EMS, which is also the idea of identification and timing. And so we covered a lot of material today, and there's a lot of substance. I highly encourage you to go back through these slides and watch back through this presentation, and then reach out to some resources about diving further into this. And if you'd like, you're more than welcome to reach out to me, and I can help you point you towards videos and discussions. We do have part 3 coming up on Monday, and we're going to talk about fighting back and the long-term effects. And we'll dive into a lot of these topics directly into there. So we've got a couple minutes, not too many left. I'm more than happy to stay a little bit longer. That's totally up to Marley and Jamie as far as timing goes. However, this is my information, and I encourage y'all to reach out and talk to me at any point in time.
We do have a question for you.
I love questions.
How often should we check or replace med kits?
Beautiful question. Each item that you buy in these perspectives and in these medical kits is going to be a little different. The one thing that I can say is we want to keep them in a secure area. We like to keep them staged properly and safely. So we want to keep them from getting wet. We want to keep them from extreme cold and heat. And then what I would do is check all of the equipment in your medical kit at least once a year. And that would be because, again, remember, we want this to be as simple as possible. So for instance, like this is here is a SWAT tourniquet, right? It's that stretching wrapping material that we got into it. It is made of a composite rubber, rubber latex, right? So if I were to let this into extreme heat or massive changes of temperature up and down, it may become brittle. However, if I keep it in its package for the most part or staged securely, and I'm regulating where it's at, this will last a very long time. And so there's no need to replace this every year. However, if I have combat gauze, for instance, and that has a hemostatic agent, it does lose its efficacy after a while, and those will actually come with an expiration date on them. And now what I want you to understand about the expiration date on combat gauze is it doesn't mean you can't use it. It means the efficacy of it is simply depleting. And so more and more and more, it's becoming real gauze. It's still useful. We just want to understand how that's going to affect it. And so that's a phenomenal question. My suggestion would be at a minimum once a year, check to make sure there's no cracks, leaks, or anything in any of the stuff that you have. Right. So if I have a gauze packet, I want to make sure that it's still sealed. If I have an ace bandage, I want to make sure that it's not fraying. It hasn't rubbed up against things and all those other areas. Otherwise, for the most part, they last a good while. I've had stuff in this medical kit that has been in there for 5 years. I check it. It's great. It works perfectly fine. And when I feel I want to replace it out, I put it into a training basket. And then I use those implements to practice. And so if I have a tourniquet that's 5 or 6 years old or they updated, then I can actually, okay, cool. I'm going to replace it with a newer version of this tourniquet. However, I still have this old one that I can practice with because I don't want to practice. And this is a great point that I didn't have in the presentation. I want to have separate material for practice because the second I use a tourniquet, it starts to stretch. And the second I open a chest seal, it loses its efficacy. So I want to have practice and I want to have staged for medical purposes. So that's a really good question. I really appreciate you asking that. Once a year at a minimum, and you're really checking for loss of integrity in packaging or loss of integrity in the way that it feels. And there's a lot more information on that resource-wise on John's website as well that you can look into that dives more deeply into that. So great question. Thank you.
We do
You
have
can
another question.
Mhm.
go ahead.
I got time.
A question from Julie. This was very comprehensive. Where can we access in-person training for trauma care and also for self-defense?
Beautiful question. Locally, if you're looking at if you're in Columbus, we haven't done it obviously since the quarantine. We haven't done one of our large seminars. We usually do 3 or 4 a year. So once a quarter, we host a 4-hour active shooter seminar, and it's hands-on the entire. So imagine what you're learning over these 3 2-hour presentations, physically training it. So you're physically going to evade, you're physically going to barricade, you're going to practice putting on tourniquets, you're going to practice fighting no matter the context. We will take your context and teach you how to do all of these things hands-on. We do that here once a quarter. We will most likely hold off until February or March of next year to see how things are going. We do offer this in small group training actively right now. So if somebody reaches out to us and they have a group of 15 or less, we will do in-person training for this and follow all safety protocols as mandatory by state regulations. So those are accessible on a private training basis from us directly. Let me put this in the chat.
I will say, guys, that the active shooter presentation has been a pretty favorite for some people. So the office is looking into furthering this partnership and hopefully creating in-person trainings in the future. So that would be something to look into.
Yeah, absolutely. The last two resources that I'm going to give you, one is again locally here in Ohio, immediate casualty care. John Grabo is based here in Columbus, Ohio. So locally, he is a phenomenal resource. In out in Texas, you have or I put in their North Star. I apologize. It's Lone Star Medics is down in Texas. So they run. I think we have one Texas person on here. Um, down in Texas is fantastic. Lone Star Medics is a great program. Dark Angel Medical does a lot where they travel around the U.S. and teach seminars like this. So those are great resources. And then we actually have if you're looking for virtual training right now, we have we call it the Active Shooter Resource Library. And thank you for updating that, medical care. The resource library, it's almost too much information. I'll be completely honest. However, it has all of John's videos for immediate casualty care. It has recorded seminars. It has copies of the books. It has copies of research links that you can go into. So there's a lot of information there. And so I can put together like a severe discount for this group so that you guys can have access to that. And that's a huge jump off. And now remember back to Monday's discussion, like the filmed seminar that we put into there were no wheelchair users and there were no people with any visible disabilities. However, we have had them in these same exact seminars. And so what I want you to go back to is that idea is if you're watching through these seminars or you watch through the footage of the training, okay, how do these concepts apply to me? And I can tell you right now, they apply across the board, and it can be very exciting to see that evolution and to realize like, oh shit, like I can do this again. Like even the short session Marley and I had only really working on maneuverability of the chair and striking. However, the concepts apply across the board. And so always be viewing it through that context. Okay, this is what he said. How would I fit into this? This is what he said. How would I fit into this? And that's a beautiful way to approach it.
We have a comment. I am glad we are recording this because it is very important information. Thank you. What is the name of Aaron's book?
Beautiful. It's called How to Survive an Active Killer, an honest look at our role in the age of mass violence. And I actually just sent a PDF copy over to Marley right before we got on this call. And so she is more than welcome to distribute that to everybody, free of charge. It was a passion project because of this. I was able to teach tens of thousands of people, and yet that's a drop in the bucket when it came to it. So I wrote the book in 2016 to help as a catalyst of getting these types of conversations going. And so everybody that's attended any of these seminars, I believe Marley is going to send out a PDF copy of that, so you have full access to it. You're more than welcome to buy one if you want a physical copy. You can find them on Amazon, but you will get that.
And we will also include the links that you added in the chat box with the follow-up email.
Yes. Anywhere the Stop the Bleed, you'll be able to find a lot of Stop the Bleed. There's a little less information. However, it's a really great start. So Stop the Bleed is the national campaign right now that I mentioned earlier.
Mm-hmm.
If we purchase the book, can we get it signed?
Oh, totally. Absolutely. Which still to this day was like the weirdest thing. When the first time anybody asked me to sign the book, I was like, oh man, this is like super kind of surreal. But yes, absolutely. It would be my pleasure and honor. I'm very passionate about this topic in that book. So absolutely.
And guys, just to give Aaron credit where it's due, within that 1 hour training that he and I were doing together, he admitted to me, he's like, I'd never done most of this before with anyone, but the fact that we're able to explore these ideas and this concept where he'll meet us as we are, I think that that's a beautiful thing. And I personally would like to see more coming from him. So,
Julie, I can absolutely sign a bunch. I think I still have a box somewhere of like 15 or 20. So I can sign a couple and and yeah, and figure that out. If anybody, if you do want a signed copy, you can reach out to me and I'll figure out how to get that taken care of.
Mm-hmm. So if I know we went over, but I very much appreciate all the comments, the questions, and the interaction. This was heavy duty stuff. We've never necessarily heard of them or thought about them in our everyday aspect if we're not medical professionals. But as people with disabilities, we understand how to work with the process and how to take care of our bodies essentially. So that body search that he was telling us about, I can tell you I do that every night with the parts of my body that I don't feel. So a lot of these things we already kind of already do, just in the concept of our disability. So now we just need to apply them in the concept of an emergency situation, an active shooter, or anything that could arise in the moment. So I want to thank
Importantly, you have,
everyone.
I just want to say you have permission to apply it in these other areas. And that is the big psychological barrier for a lot of people, is we don't feel we have permission. Like, that's not something I can do. That's not, you have permission to do whatever is necessary to protect yourself. Top to bottom, you have that permission, and take it and run with it. And that includes a bunch of awesome stuff that you already do day to day, day in and day out, simply applying it to this new context and knowing and being powered with the idea that I can.
Mm-hmm. Just alone the concept of communication, how many of us have to direct someone on how to properly put our clothes on, how to properly care for a wound on our leg, anything, how to reach something for us. Like, there are so many things that we constantly have to improve our communication skills on. And when I was doing the research on this, a lot of the same things that you mentioned are things that I keep hearing, like the medical professionals or the police department. They're not there necessarily for you. They're there for that threat first and foremost. So thank you so much for reiterating that concept and that idea for us.
Oh, thank you for having me. And
Absolute pleasure.
yeah, it literally has. I'm thoroughly enjoying this, and it's been an honor to be here. I'm looking forward to Monday. And
Me
then I'm
too.
looking forward to the next step, however I can support you all going forward.
That would be awesome. Thank you so much, Aaron. Everyone, I very much appreciate you all for being here. I appreciate Jamie for her tech support. I appreciate PRI captioning for their wonderful skills. And I look forward to our final active shooter, part 3, the fight and the aftermath on Monday from 10 to 12. Have a great weekend, everyone.
Take care.